Assalamu alaikum, everyone. We're really sorry for the delay. Can you please confirm if I'm audible? Hello? Am I audible?
Welcome, Sam. Yes, Dr. Maria, you're audible now.
Thank you, thank you. All right, so we are already late to start the session. So may I please request Dr. Furqan? All right, so Dr. Furqan is here with us at Oman University right now. So Dr. Furqan will go live from here. This is the continuation from the previous session, which was conducted last month in January regarding the whole brain radiation versus stereotactic RT in brain mets. So I had to thoroughly introduce Dr. Furqan, but in the interest of time, we will rightly begin with the presentation. Over to you, Dr. Furqan.
Assalamu alaikum, everyone. Thank you, Maria, for letting me speak to this wonderful audience. Okay, so can we start now?
Yes.
Start. Okay, so last time we discussed some of the LOs which were provided before, and because of the time restriction, I could not complete the whole thing. And so today I'm trying to complete the whole LOs one by one. And previously we discussed about surgery versus stereotactic radiosurgery and the patient selection, and we discussed about some of the parameters we take while selecting. So last time we discussed some of the LOs, and those are based on the one which you provided, and we discussed about the whole brain radiation therapy. How do we select our patient and the different tools we use in each scenario?
Yes.
Okay. Sorry for the interruptions. Okay, so just let me jump to the main topic. Okay, last time we completed up to this part, so here it's a new presentation from here. So the re-radiation in the brain met. So what are the issues with it? Necrosis, and what is the whole brain tolerance? Okay, so we will talk about this. So whenever we are talking about the re-radiation in the brain metastasis, certainly it is possible, and it's quite often we always do it. So whenever you are having any patient and possibly coming to you for a radiation, and they will possibly have two scenarios only. Either that patient may have received a whole brain radiation or already had a SRS. If patient had a SRS and if is coming for the repeat radiosurgery, then either it could be a new lesion or it's a radiosurgery for the same lesion which is progressing now. Generally, this scenario where the lesion is progressing after first RS, it's rare. It doesn't normally happen unless the previous radiation we missed the target or the dose were not sufficient. Only in that scenario this thing happens. Otherwise, most of the time the scenario is only the whole brain radiation or it's a new lesion. Okay. So So what doses we are going to use if patient has already received the whole brain radiation therapy? So there was a very famous randomized controlled trial which was published around year 2000 something, and they basically tried to use a different dose level based on the sizes of the tumor. And from 0 to 2 centimeter, they tried to deliver dose 24 gray, 2 to 3 cm, 18 gray, 3 to 4, 15 gray. It was a dose escalation study, and they established that this is the doses or the max dose we will be using based on the diameter of the tumor. So all those patients they selected in this study, they already received prior radiation. Either it was a whole brain or either it was a focal radiation, because some of the glamour patients were also included this. So based on this study, we can certainly conclude our dose. In fact, these doses are still in practice and we always follow this one. That is a separate talk whether we are still following the diameter or the volume, but all the volumes which we are using are derived from these diameter actually. So if we are saying 14.4 cc of the volume, that means a 2 centimeter of the diameter. So all those volumes are derived from this. So if patient have received whole brain radiation therapy before and it's a kind of re-radiation to brain mets, we can certainly do radiosurgery with these doses, and RTOG 9005 certainly supporting the re-radiation with this much of the higher doses. We can easily do it. So no issue if patient has whole brain radiation and it's a radiation. So I always try to deliver, especially if the tumor size is more than 2 cm, I always fractionate. It's easier for us because the chances of getting a radionecrosis is low, and generally it's more safer. So whenever a tumor size is more than 2 cm, I fractionate into 3 or either into 5. And 27 to 30 gray or 30 to 35 gray. NCCN suggests 27 gray in 3 fraction or the 30 gray in 5 fraction. But if the tumor size is allowing you, you can easily go up to 35 gray safely. There is no issue. But if you are using some technology like a VMAT kind or VMAT or the rapid arc kind of radiosurgery, then you most of the time use a 2 millimeter margin. And in the last presentation, I have explained this thing. If you are giving a 2 millimeter kind of margin, certainly you increase your volume more, especially if tumor size increase from 1 cm to 2 cm, the perimeter of the tumor or the volume, it increased significantly. In fact, sometimes it increased up to 50% just by adding a 2 millimeter margin. So that's why if for the VMAT or the rapid arc, if the tumor size is more than 2 cm, it's better you fractionate in a 30 gray and a 5 fraction. But if you are doing a dedicated radiosurgery system like gamma knife or the saber knife, we generally keep our PTV hardly 1 millimeter, so it doesn't increase much of the doses. So we can escalate the dose in those areas. So if the scenario, can we move this? So if the scenario of patient has a prior SRS and now patient is coming for the re-radiation. So the first scenario was I mentioned about the whole brain and patient is coming for retreatment, and now patient had a SRS and patient is coming for the retreatment. If it is a new lesion, certainly you have a very flexibility. You can easily deliver the max dose, the one you had delivered before to other region. For example, if patient has one lesion on the right cerebral hemisphere and the second lesion is coming on the left, no issue at all. You can certainly give the full dose. But issue arises if the tumor or if the new lesion is at the margin of the previous acidosis line, previous tumor, it will certainly increase some issue. So in that scenario, rather than taking it as a new lesion, just consider it as a marginal failure. And in that case, we have to reduce our doses. So if there is a new lesion, if we are doing a radiosurgery, we can certainly give higher doses, full dose I mean. And if there is any progression into the previously treated lesion or at the margin of the lesion, we have to reduce our doses. And there is one paper published last year where they have re-radiated the lesions which were previously treated with the SRS, and what they have noticed, if they try to achieve V12 under 9 gray, still the chances of having a radionecrosis is 20%. So if we are doing a re-radiation to a lesion which has been treated before, we can certainly treat, because that patient doesn't have any other option. If he can have a surgery, well and good. If he cannot have a surgery, no other option, no systemic treatment, no target treatment, we can do radiosurgery, but the chances of radionecrosis in that scenario will be 20%. And this is true for if the lesion size is less than 1 centimeter. We have to keep this in mind. If we are having a lesion size like 2 centimeters, certainly we cannot even achieve a V12. In that scenario, the chances of radionecrosis will be much, much higher. And generally, this necrosis, this happens after like 6 months, as early as it may even happen in 4 months as well, especially in the re-radiation cases. But it's rare to have radionecrosis within 6 months. Generally, it takes 1 year. So if patient with the metastatic disease, with the recurrent metastatic disease, generally we don't expect a survival more than a year. So usually we don't consider risk of radionecrosis, especially if the size is lower. We just proceed it. But we have to explain this to the patient. Luckily, if patient survives for more than 2 years, we have that he should be ready. Okay, so this thing has to be clearly explained to the patient. So re-radiation in brain metastasis certainly possible. Okay. So next is, can we offer SRS and SRT simultaneously to the multiple brain lesion? Yes, we can. And it all depends what planning system you are using. In RapidArc, yes, it is certainly possible, and we have done some of the planning. And especially if the lesion is in the lower part, for example, in the brain stem, and we have a limitation to deliver a higher fraction size, we generally fractionate it. So all those upper supratentorial lesion, we can certainly deliver in the single shots, and at the same time, we can deliver the dose to the other area which we want to fractionate. That is possible. The only issue there will be the cumulative dose, and to bring down a common radiobiological dose, it's sometimes difficult. So if the lesions are close by, like if their 50% isodose lines are overlapping, it's better than, rather than doing a SRS and SRT simultaneously, better you do a fractionated SRS to all the lesions. And generally, I used to prefer this thing. In 7i, we always did the fractionation to all the lesion. We never kept it like this, delivering a single shot to one area and then a multiple. It's always difficult to calculate the doses. Okay. So if you want, you can, and especially if the lesions are quite far away. Okay. Okay, so when should we consider DEXA dose during treatment of brain mets, and what doses of DEXA, duration, tapering is required in a patient? It's a very difficult topic. Basically, generally we try to avoid this thing. If we have a medical oncology or the palliative care team available with us, we always push our patient to go with them. But generally, if we have to do, because when I was in Savannah, we used to prescribe dexamethasone on our own, and so usually we don't just give the full doses to all the patients. We select our patients. For example, if patient is asymptomatic, we don't even prescribe DEXA unless we are starting a treatment. Because if patient is asymptomatic and if we start radiation, so the edema is exaggerated with the radiation whenever we treat. So in asymptomatic patient, we always prescribe dexamethasone only during the treatment. It was a short course only, 5 days or 7 days, that's it. We sometimes we just avoid to giving a longer doses in asymptomatic. No, if we are delivering a 5 days course, we don't even taper off. Generally, we try to give 1 day before, and if you're not giving a 1 day before, just on the same day, it's fine, because first fraction doesn't cause anything. It's basically the second week which is the most troublesome. So if patient is a mild symptomatic, having a mild symptoms like some headache, some vomiting, but controlled with the antiemetics, common antiemetic like gravinate or Maxilon kind of thing, no need of giving some stronger antiemetic, and doesn't have any sign of herniation, nothing there, and no midline shift. So those patients are taken as a mild symptomatic patient. So in those patients, we start our dexamethasone with the 4 to 8 milligram per day. Once the patient is diagnosed having these kind of symptoms, we just start simply. We just don't wait. But in asymptomatic patient, we only start with the treatment. But with mild symptom, we start from the day one. When the patient diagnosed, confirm on the MRI, we start Dexa. It is important here. And during the treatment, we continue the same dose. And once after second week, especially when the symptoms resolved, and we start tapering off. Generally, it takes at least 2 weeks. At least 2 weeks. For patient with severe symptoms, 16 milligram dose per day, and it's a 4 milligram 6-hourly dose we usually prescribe, and it started immediately. And sometimes we have to continue this dose to 4 weeks, or sometimes even up to 8 weeks. And in fact, in some of our patients who had larger lesions and more symptoms, we had to continue for the 3 months, in fact. And because those patients doesn't have any other option, especially in the brainstem metastasis, and the space is quite narrow there. Because if brainstem is having edema, it doesn't have any other space to push some other area, unlike cerebral hemisphere. It can go to other part and other opposite side. But in the brainstem, there is nothing. So sometimes we have to keep giving the dexamethasone up to 3 months. And of course, there will be a side effect, but side effects are better than losing a life. So for low dose administration, like the one I mentioned, 4 to 8 milligram per day, we taper off in 2 weeks after resolution of the symptoms. And for high dose administration, taper off in 4 weeks or sometimes longer. Okay. And as I mentioned, second week post SRS, patient have the most or highest edema in the second week. And same is true. In fact, if we are doing SBRT in some other area, it's not like if we do a reduced surgery or the SBRT in the morning, patient is going to have any symptom in the evening. No, nothing like that. Doesn't happen. So this edema takes a time to develop. So focal versus diffuse meningeal involvement, and how do we handle this situation? So basically, whenever we talk about the meningeal involvement or the leptomeningeal disease, so basically leptomeningeal disease is basically of 2 types. It's a linear kind and the nodular type. The one you are seeing here, so basically it's a classical linear. So you are seeing this folia. Okay, so there is enhancement, clear enhancement on this T1 contrast image. You can see here. Okay, and you can also see the gara here. Okay, these are enhanced. These are going inside. This is not a vessel. These are basically the enhancement of the meninges. So if you are seeing a normal vessel here, it's generally present in this part. But if you are seeing a meningeal thickening or the meningeal involvement, this enhancement goes inside the gara, here. On this part, it's not that much prominent. So if you are seeing in the hemispheric area or the convexities, if it is not prominent, always look into the cerebellar areas. If the folia is having this much of enhancement like this, always take it as a leptomeningeal disease. Great prognosis. Okay. So treatment, of course, whole brain, and after that, it depends upon the institutional practice. Intrathecal chemotherapies, if your institute is comfortable with, some institute do not even give any intrathecal. So it's all depends. So first establish whether this meningeal involvement is a diffuse one or it's a focal one or it's a linear one or it's a nodular one. Okay. Sometimes because these lesions are present on the gray white matter, and when they enlarges, it pushes the free space, and generally the free spaces are just under the skull bone areas. So it touches the meningeal part almost all the time whenever it's on the surface. So it gives a pseudo impression that in that area meninges are involved, but that's not true case. And this is mostly due to the vascular engorgement in that area. So whenever the tumor is in this area like this, and you may have a feeling of possibly the meninges has been touched, it is involved, but no, you may have some enhancement on this meningeal site, but that is basically due to the vascular engorgement. So in this scenario, we don't take it as a meningeal involvement or the leptomeningeal disease, we will still take it as a focal area, focal parenchymal disease with meningeal involvement possibly in the focal area. So what treatment we are going to offer? We will still offer a focal treatment, SRS, SRT, whatever. Okay, no need of doing any whole brain radiation in this area. Okay. One more example you can see here. Two lesions close by. In fact, in this focal area, we can clearly see there is some vessel as well, and possibly some meningeal enhancement in this area. It may give an impression of possibly involvement of meninges or leptomeningeal disease. But when we look into his cerebellar area, the folias were very clear. So we decided to proceed with the focal radiation only because there was no evidence of diffuse involvement. So we just did radiosurgery here. Same here in this case. Seems like a meninges is in this area, looks like involved, but other areas were clear, and so we proceeded with radiosurgery. And in this scan, in this slide, I mentioned about the linear involvement of folias. There is one more involvement, one more type of involvement that is called the nodular involvement. That could be a without symptom. Yeah. Yes, we can certainly miss, because even in the leptomeningeal disease guidelines, they have clearly classified patient based on the symptoms as well. Patient with the symptoms, patient without symptoms. That is also taken as. So in this case, you can see possibly there is a parenchymal disease, but it's not just a parenchymal, there is definite meninges involvement. Because this type of diffuse tumor or diffuse lesion is not a classical for the parenchymal brain met. This is a nodular meningeal involvement along with parenchyma, but no other leptomeningeal disease anywhere. So leptomeningeal disease guideline, and this has been published I think 2 or 3 years back, and they clearly mention this thing: if it's a diffuse or if it's a nodular focal involvement, there is no need of doing any whole brain radiation therapy. Yes. Yes. Exactly. Exactly. So yeah, exactly. So basically, if you look into the parenchymal lesion, they are always circular. Almost. Just 99% of the time, if you are having any lesion, they will always be circular. Always. Parenchymal. And if you look into this lesion, this is not a circular, this is not a sphere. Okay. Tino dimension. It's an irregular shape. Okay. So most likely, it's a nodular involvement of meninges along with the parenchyma. Of course, you can only confirm with the biopsy, but 99% chance it's a nodular involvement. So what treatment we are going to offer, and the radiologist might write it as a leptomeningeal disease, but it's you who are going to decide what should be the treatment here. It's a focal involvement, no other leptomeningeal disease, no diffuse involvement, focal treatment, that's it. Okay? And it is supported by the guidelines. Okay. Same here. This is not a classical area. No classical round shape. It's going along the gyri. So here it was one of the gyri from here, and it was evolving like this. Exactly, most likely. Okay. So this is also one of that case. Same here. So these both scans are of a same patient, are very thin or linear kind of, or linear kind of nodule here along the gyri. It was along this temporal lobe parenchymal involvement, as well as this nodular involvement. There was one more lesion somewhere else. So in this patient, possibility of meningeal involvement was there, but it was nodular. We proceeded with the radiosurgery as well. Okay, and in this patient we did radiosurgery, I think in mid of 2020, and this patient is still surviving. I just had a talk with the family. Is still surviving, and same disease. I mean, primary it was a lung CA. So mostly, so whenever you are seeing a breast cancer with the HER2 positive, and always expect a leptomeningeal disease. If you are ruling out leptomeningeal disease, only in that case you proceed with radiosurgery. Always rule out. HER2 positive, ERPR negative, very high chance of leptomeningeal disease involvement. And especially if patient is having a multiple mets, and if it is involving both compartments, supratentorial, infratemporal, even it's a immediate stage disease, rule out leptomeningeal disease, because those patients have a very, very high risk. So generally what we say, if any lesion, any primary lesion is an adeno-CA, and these adeno-CAs have a high tendency of leptomeningeal involvement, not in the squam. It's typically adeno. So breast, it's a glandular tissue, adeno of course, lung adenos, and other type. Always rule out leptomeningeal disease.
Special MRI sequencing.
No, same one. Just a, but we volumetric imaging. So especially in our Sultan Qaboos Center, what we do whenever we are doing MRI for the brain metastasis, especially, they always do their routine MRI, always. But they include 1 to 1.25 millimeter cut is MRI, especially the T1 contrast only. One sequence they keep it for that, because of course they cannot do all the routine sequences in this much of the thin, because otherwise it's gonna take 3 or 4 hours. But at least include one, so we will not be missing any even the nodular or whatever the involvement here. But of course, failure sometimes, especially in the brain cerebellar area, it gives some information as well. But mostly it's a T1 contrast which gives the most information. So again, this patient, no typical parenchyma involvement you can see along the folias, but it's a limited. No other diffuse involvement. Here as well, it's a gyral area. Okay, so it's a leptomeningeal disease, but it's a nodular one, and prefer to have a radiosurgery, and we did the same. Okay. So leptomeningeal disease, rule out the diffuse one. If no diffuse one, rule out whether it's a linear one, because in the linear one you cannot do a radiosurgery. You can only do radiosurgery in the nodular leptomeningeal focal involvement. Okay. So which imaging sequence is used to mark brain mets and any role of T2 flare? I've included 3 or 4 LOs in a single one, because they are almost all related. Okay, so post-op cavity, follow-up schedule, MRI interval, and the role of CT with contrast. Okay. So for the MRI, so you need 2 sequence, T1 contrast 3D, and the second one is flare, more than enough. If you can do fat side contrast, that's good as well, because sometimes in some of the areas, especially in the post-op cases, it's always difficult to differentiate whether it's a radiosurgical, it's a surgical change, or whether it's a actual tumor. So in that scenario, it's the fat side which basically sometimes differentiate between the actual tumor and those changes. So for the T1 contrast, we always take 1 millimeter or 1.25 millimeter. I prefer 1 millimeter at least. And the flare, for the contouring purpose, it will be contrast which will always be used, always. Never go any other sequence. Even sometimes you can see a better image in the flare as well, but no, we never use the flare. It will always be a T1 contrast. So why do we perform this flare sequence along with this? So basically, for the small lesions, like maybe 1 millimeter or 2 millimeter, and you may find a lot of small enhancements when we are doing a T1 contrast 1 millimeter cuts. So not all the lesions, not all the enhancements are the T1. So if your flare sequence is correlating or showing the edema on the same area, take it as a MET. Okay. Or you just scan out the flare sequence. If you are seeing any high signal area, always compare it with the T1 contrast. If it is also showing the enhancement, that is a MET. If it is not showing enhancement, it's a low signal on the T1, it's a ischemic area, ischemic change. Always, we always take T1 contrast in the flare. Never go with only single sequence. Possibly you're gonna miss a lot of small metastatic foci.
T1 weighted is, in fact, tumor is for T1
Exactly,
gold standard as a surrogate
as a
and then with contrast.
with
This
contrast.
is some very important lesson which we learned.
Yeah.
I was just wondering that for your work, it was more like a diffusion weighted, but I think it's more going towards
So
normal
basic-
conventional T1 weighted, which was from over time.
Yeah. So basically, diffusion weighted images, they are only used to characterizing the lesion, whether it's a glammatic type or some other type. Sometimes it's also used to differentiate between some infection, some other. Yeah, basically, it's differentiate between the cerebral CSF flow within the lesion or no. So we don't use it for our metastatic disease anyway, not even for the diagnosis. Okay, if patient have a very clear diagnosis of metastatic disease, we just only go for the T1 contrast. No need of DWI, no need of ADC at all. So for contouring T1 contrast, flare, just to look for the new lesions and compare it with the T1. That's it.
Flare, please explain flare in simple words for all of
Okay.
us.
Okay. So
Flare
base.
means how to flare, how to flare.
Okay, so basically T1 and the T2 image, I think most of you can differentiate, or just remember the word W, which www. And in fact, I learned this thing when we were doing refreshers in 2011, 2012 time. And so basically in word 2, you will find W, and just take that W as a white. So in the T2 W image, the CSF or the fluid will be white. All the water will be white. Okay.
Two white water.
Two white water. Okay. So if we can make some system-based changes or some algorithm in which we can just subtract the CSF fluid, then only parenchymal fluid can be visualized. That sequence will be called flare image. Fluid attenuation inversion recovery. It's just opposite of T1 contrast. Because in the T1 contrast, in the cortical area, you're gonna see a dark area. And just underneath it, the white area you will see in lighter color. I will show you some image. For example,
Flare to just, I mean, flare like a शरीर मतलब गुस्से में आता है ना वो फ्लेयर अप कहलाएगा एक आदमी सारी जिंदगी गुस्से में रहता है वो नहीं करता तो
Yeah.
ये नॉर्मल पेशाब रहता आराम से
Hmm.
उन्होंने पहले सबमर्ज किया उधर से ऑफ कर दिया
Exactly, exactly.
अब कोई तो गुस्से में आ रहे हो there is something wrong.
Yeah.
So flaring is from the parenchymal side.
Yeah.
ये बड़ा important है
Exactly.
है
Hmm.
CSF साइड यदि फ्लेयर करता है हमारी बला से हमें कुछ
Hmm.
अब CSF आपने आउट कर अब क्यों फ्लेयर कर रहा हो ये गुस्सा आ रहा है किसको शरीफ आ
Hmm.
रहा है
So this is a T1 contrast image. You can see in the T1, the cortical areas, basically these are the nuclei, these are the gray matter. It will appear dark and these are the white areas, white fibers, and these are light. So in flare, this pattern is inversed. So that's why we call it inversion recovery. So this, unfortunately, I don't have any clear image on this presentation. So this dark area will turn into more whiter, and this white areas will be converted into more dark area. So this is what happens in the
We
fluid.
frequently see it in the primary section.
Yeah.
Frequently see.
Yeah.
ठीक है,
Mm.
Thank
Mm.
you for
Mm.
elaborating.
Mm. Okay. So in post-op cases, okay, I will discuss again. So CT, so I always prefer to have with contrast. Some physicists and some people, they say no, it will increase the density of the image. It may give some wrong information on the dosimetry, this and that. No, it's possibly gonna give only 1%, 2% kind of change, not more than it. It is a contrast, it's a fluid, it's not a bone which is going to harbor your radiation penetration, nothing else, nothing like that. So always use CT with contrast if possible for you, unless there is a contraindication, unless there are some other issues. Always use CT contrast, because it's not only going to help you with the tumor delineation as well, it will also help you to compare your fusion. Because whatever the method you are going to use, even if you are using a deform image, there will always be a chance of some mismatch, always. Even if you try to match on the vertex area, there will always be some changes in the skull base part. If you are matching a skull base part, then there will always be an issue with the vertex part. So it's better to have a CT contrast. So just in case if you are missing any part, you can correlate with the CT contrast, because a metastatic lesion, they enhance very well as well. But of course, for the delineation, you will be using the T1 MRI contrast. But the CT contrast, it will help you not only in the delineation as well, also to confirm your matching as well. Okay, so I always prefer to use it.
Historically, just for your information, historically it was our general teaching that all planning scan has to be without all from head. to
Yes,
toe.
yes.
But there was a real reason behind that. They were previously 2.5D type of planning system. Plateau. I worked on Plateau with HELAX.
Hmm.
They were not having that sophisticated Hounsfield unit issue.
Exactly.
Now you have Hounsfield, sorry. So Hounsfield is there, it makes no difference.
Exactly.
Anything you like. So, but historically, you will find old timers who will ask you not to put contrast. But that was the history of it.
Yeah,
But
exactly.
now you can do,
Exactly.
because for contrast, it will look very good for us to delineate. You may get it wrong for 2 to 3%, but not more than that.
Not more than that.
ठीक है ना, clear हो गया ना सर? कोई आपके बड़ी उम्र का आदमी बैठा हो आपके क्लास में, पूछने के भी क्या मसला है?
Okay, okay. So for the follow-up,
दो मुंह के लोग आए.
with radio surgery, it's always preferred to have a 3-monthly one. If you are offering a whole brain, so some of the people, they don't even do a MRI scans, they don't do a follow-up scan, they just consider them as a palliative one, gone case, don't do anything. But if you are doing a radio surgery, we always push to have a 3-monthly follow-up, because in case if there is any new lesion, we can certainly do radio surgery. Okay, and this will continue for the whole life. If patient is surviving 2 years, 3 years, or whatever, it will continue. Unless patient is a very a long survival, like 2-year kind of thing, then you may skip to 6 months. But generally, it's a 3-monthly follow. Okay, post-op cavity. So recently, I think 1 year or 2 year back, we had this guidelines for the post-operative cavity delineation in the brain metastasis. So to be honest, it's a very difficult site to treat, and I always prefer to have an intact met rather than the cavity one, because it increases the volume a lot. it increases the normal tissue doses, it increases our meningeal side of doses. There's always a trouble. So if you are having any lesion, and if you expect your neurosurgeon is going to do only a partial debulking, then it is better to always offer SRS unless it's a therapeutic surgery, like due to a midline shift kind of thing. Okay. Otherwise, just offer radiosurgery, and we discussed in detail in our last session about this. So the delineation, it will always be based on T1 contrast, and I prefer to add fat set contrast as well here, because they rule out the surgical changes, because by the time after 6 weeks or 8 weeks, the patient will be coming to us, and sometimes we have some difficulty, and sometimes patient just come to us within 3 months, within 3 weeks. And because it's a metastatic disease, we generally don't prefer to wait quite a long time. We have to start it as soon as possible. It's not like a glioma, we have to wait for the 4 weeks or the 6 weeks kind of thing. We have to start as soon as possible. So if we can do after 3 weeks, fat set contrast, it helps a lot. Okay. So what's the difference while we do contouring for the cavity, and what doses we prefer, and what areas which are taken into consideration in special focus, I mean. So the meninges is the basically special focus here. We try to include the 4 to 5 millimeter along the meningeal point, because once the meninges are disrupted after surgery, they are at risk of developing metastatic, because these are kind of loose areas, and whenever they are resecting out the tumor, and there is always a contamination. So always include a meningeal part 4 to 5 millimeter if you can, if possible. And if there is a bone disruption, we try to include the undersurface of it as well. So this is one example. So this patient had a surgery, and you can see the meningeal enhancement from here to here, and we don't know whether this meningeal enhancement is due to tumor, it's just, or possibly it could be a surgical change as well, or it could be a vascular engorgement as well. But we did not want it to take any risk, so we included it. So
Just the devil's advocate, as a learner,
Yeah.
asking you a question. Does not it coming in our arena of fractionated log?
exactly.
Because
So what we did,
is
so
1/5 of the whole brain. No,
so
1/5.
it's not a, yes, it looks like a 1/5 of the whole brain, but so certainly we did not do any kind of single fraction one. We did the fractionated one, 5 fraction.
Fine.
So it was a 5 fraction radiation, 5 fraction radiosurgery, and we always take a V28 or V29 in control. So if we cannot achieve V29 gray under 10 cc or the 12 cc or the 15 cc, so we take some other approach, like we treat in alternate days.
So what is in your mind? You are thinking about the future because of prognostication of the patient? Because I could have easily considered him for whole thing, 20 in 5,
So
but maybe I'm wrong.
So if you are delivering a 20 gray in 5 fraction to a patient who is only having a single focus area, so unfortunately he had a surgery, but it's still a focal disease. So if we are delivering a 5 fraction whole brain, so why not to deliver a focal radiation in a 5 fractions? Okay.
That is the paradigm shift.
Hmm.
That's why I was highlighting this.
Hmm.
Then we have to refer patients for second opinion if we don't have a facility. We have a facility, but we are not using it. In fact, we can use it here. We have a stereotactic full facility.
Yes.
Fair enough. So this is very important today's learning point.
Because this is unnecessary. Because if we don't have any evidence of having any other metastatic lesion on any other area, so it's not justified nowadays, especially to do a whole brain.
So primary has to be fully controlled. No other focus of metastatic disease elsewhere.
Even that concept is gone now, because people used to take it before, like primary should be controlled or no evidence of disease, 3 lesions only, and prognosis, performance study should be good, this and that kind of thing. Not anymore.
Very good.
Unless
Another
patient is having a ECOG status of like 3 or 4 kind of thing, only on those cases we prefer to have a whole brain. Otherwise, it's always a focal treatment.
अभी clear हो रहा है? Because you लोग आजकल ये कहते होंगे, in the horse,
With the availability of technology.
don't look in the field.
It is not rationalized to.
In the farm, look in the field.
It's not with the availability of
Except for audio,
technology,
yeah.
actually it's not rationalized to further deteriorate the performance status. only with the
Exactly.
treatment option.
So we discussed this thing, this prognostication, this prognostic criteria. We discussed in our last session. So no doubt, maybe I think 10 years back we used to take this as well. More than 3 lesions, no, we are going for the whole brain more than 5. So now we take as a 10 lesion at least. We are comfortably treating 10 lesions with the radius surgery without considering for the whole brain, those kind of things. So that concept is out.
Another paradigm shift that we're learning, and immunotherapy is also like
Exactly. Because these patients are having so many of the systemic treatment options, not just the chemotherapy, they have a targeted therapies, they have a immunotherapies. Now they are surviving for more than a year or 2 years or 3 years. So these patients who gonna have this whole brain kind of thing. So, and we discussed there are a lot of side effects associated with it. So it's better to offer a focal treatment always. And especially if we have a free facility available in a city, it's always better to have. Okay, so doses of lesions versus post-op cavity. So we follow the volumes. 14.4 cc, basically this corresponds to 2 cm. Okay, same, the one which was mentioned in the RTOG 9005 study. So 2 cm diameter actually corresponds to 14.4 cc. So in the post-op cavity, you're gonna see that we have slightly reduced our dose, 80 to 20 gray, slightly reduced. But take this thing in mind, this is for the cavity, total dissection. If there is a residual disease, you will be going for the higher doses, 24 gray, the one which we use for the intact tumor. Because if it was a 50% of the tumor left, or if it is a full tumor left, tumor is there, we have to radiate with the full dose, that's it. Unless that's a clear gross tumor dissection. In that case, we are going to reduce to 20 gray, otherwise full dose. So if the volume is more than 14.4 cc, fractionated, that is better option. Because when you start contouring this cavity areas, there will be a lot of confusions while you are contouring, and you will be ending up including a lot of normal area. So it's better you fractionate in a 5 fraction, because the risk of the necrosis will be less in that scenario. Plus you will be comfortable that you are not missing anything. Okay, so if you're doing a single fraction, then no, it's better do a fractionation one and include slightly more area.
Even these 3 fractions, they were like consecutive 3 days or like alternate 3 days?
Depends upon the volume. If it is small volume, you can do 3 days continuous, no issue at all. If it is a large area, like if you're doing, for example, 14 cc, let's suppose, go ahead with the alternate days. Okay, alternate days.
And if there are multiple lesions, which we are offering 9 and 3 or maybe 6 and 5 at the same time, even then alternate regime or 2 weekly regime, something like
So
that.
unless we are violating our V29 in 5 fraction or our V23 in 3 fraction, if we are violating it or we are reaching at the limit, fractionated. So basically this fractionation came into play when you start having this limitation in the single fraction. Okay, if you cannot achieve V12 10 cc, fractionate 3 fraction. 3 fraction is difficult, 5 fraction. Okay, if 5 fraction is difficult, then you have to accept or give alternate or just proceed with it. Okay.
Words which are less
Somebody
than
knows cynically. Maximum you have a friendship of 10 days.
10 days maximum.
You have already seen RS.
for tumors less than 14
Maximum की बात.
Hmm. So-
for tumors which are less than 14.4 cc, so is there any evidence or outcome or suggestion that you should give a patient 5 or less than 14.4 cc? Obviously, you would like to do advanced as patient convenience and all those things, but is the local control worse if we fractionate or less than?
No, so luckily we had a phase 2 kind of studies and some of the retrospective data as well, and there is no difference in the local control as well as nothing. It's no difference even for the small t. So basically, it's all about the convenience. So we reduce the toxicity while we're doing a fractionation, and it's better to have a single fraction. But if you are having this much kind of tumor, because what's gonna happen if you are increasing your dose? I mean, if you are increasing your volume, you are reducing your single fraction total dose, right? For example, if you are treating 3 to 4 cm, you are reducing your dose to 15 gray, right? So you're jumping from 24 gray single fraction to 15 gray, your control is already compromised. Okay. Exactly. It's already a compromised dose, even with a single fraction. So why not to fractionate it and slightly increase more? For example, this 35 gray or 35 gray in 5 fraction or 32 gray in 5 fraction is equivalent to 18 gray single fraction. So the tumor which was supposed to get a 15 gray dose in a single fraction, now radiobiologically is getting an 18 gray dose. So it is not lesser by any means radiobiologically. In fact, it's better. Okay, so you are escalating the dose in a fractionation and reducing the toxicity as well. Okay.
Is there further suggestion of having a dose escalation so are able to control organoids beyond 20 grains?
Of course you can. Of course you can. So it's not a hard and fast rule. If you can escalate the dose, like I always say, all your radiosurgical doses depends on your organ risk. If your organ risks are well under control, escalate the dose to a certain limit. Not like you are going to deliver 30 gray here. No, you will certainly induce that necrosis there.
So technically, you use the homogeneously total volume dose or you just make the most part more
No, so basically we increase the total dose.
homogeneous.
Yeah, more homogeneous dose. For example, if the prescription was 20 gray and we can certainly achieve our V12 to under 5 gray, 6 gray, we increase dose to 21 gray, 22 gray, 23 gray. We go like this way. Okay. And we just try to keep our isodose line to 80 gray, especially if you are doing a Linux based. And there is a logic behind why Linux based isodoses are more stable at 80%. Okay. So we don't increase inside the tumor. Okay, it will be 80%, maximally 75%, maybe 70% sometimes. Okay. Okay, during treatment monitoring, what are available options in Linux and CK? So in CK, we have this 6D skull tracking. So it's basically it gives us some millimeter accuracy. And so basically it acquires 2 obliques images, one from here, one from here. Then, so it matches the pixels basically. It's not just like any person is matching. It's there is an algorithm which matches the pixels of this image. So it gives all the 6 possible areas which is trying to match on the image. So you can see there is one example. It's under 1 millimeter even, matching there. So for the Linux based, there are a different system. The simpler one is always a CBCT. And I think you have CBCT. So CBCT, the most simplest one. And if you don't have any advanced one like the one in the Brain Lab Exact Track, and especially this system is very much famous with the Novalis Brain Lab. They use this Exact Track, and it's similar to CK1. And they use infrared as well as the oblique images. So, but if you are using a CBCT and only using a cone beam CT for the imaging, it's better you improve your immobilization if you want to achieve a good radiosurgical doses. Okay, so if you are not using a good immobilization, you better get a better tracking. So in CK, we use a frameless mask, and that is because we have a better tracking system. Same goes with the brain lab. We use a simple thermoplastic mask because we track easily with the infrared as well as the fluoroscope, easily. But if we don't have any onboard tracking, that means an intra-treatment tracking, you just take a CBCT and treat, it's better have a good immobilization. That is the most important thing. Okay, it's not just like you have taken the image before the start of treatment, fine, let it go. No, you hardly have a 5-minute or the 10-minute treatment for the VMAT or the rapid art. So you cannot do intra-treatment tracking, nothing like that. Okay, so if you can improve your immobilization or the specific, or you can say there are some specific stereotactic immobilization available for the CBCT, use them. Okay, so not only depend on CBCT, use stereotactic immobilizations. Okay, or otherwise you will be using a larger PTV. Okay, 2 millimeter or sometimes 3 millimeter. Of course, not suitable. Okay, so how do we minimize the chances of necrosis in brain? Okay, so we have discussed a lot about the V12, V28 infractionation, V23. So based on those discussions, how do we minimize the chances of necrosis?
What do you think that like you have very precise then the equipment is very precise again. The margin is based on that equipment, which will reduce the dose of power.
So these are all the secondary things. If your equipment is not optimized, don't do radio surgery. That is not radio surgery system. Okay, so we are doing a radio surgery.
I think the regime selection, the patient selection.
Exactly. Okay. So basically, we have a defined parameter and always discussed all the time. We are talking about V12. Okay. If your V12 less than 10%, you only have a 5% chance of developing radionecrosis. Okay. So how can we minimize the risk of radionecrosis? Keep your normal organ, normal tissue, normal brain parenchymal dose as low as possible. Okay, so V12 less than 10%.
And we have a range of going up to V28.
V28 if we are doing a fractionation.
Fraction.
If we cannot achieve a single fraction tolerance limit, fraction it. Go with the 3. Even if that is not achievable in a 3 fraction, go in 5 fraction. Okay, we fractionate it. Okay, or what we can do. So you have seen if we are doing a CBCT based tracking, CBCT based onboard imaging, we have to increase our PTV margin, 2 millimeter margin. In CK, we hardly use 1 millimeter margin. If the tumor is large enough, sometimes we just skip the margin. Okay, sometimes. Okay. So if we are giving a 2 millimeter margin, certainly it will increase the V12. Okay. So it's better use a stiff immobilizations or you can say a dedicated stereotactic immobilization. You will be good to go. Even I have seen people are using true beam for the AVM radiosurgeries. They are using it. And why they are using it? Because they are using a specific immobilizations. Okay. There is no issue with it. So good immobilizations, under control V12, the risk of radionecrosis will be very, very less. Okay. This should be kept in mind. One more important thing. Image registration, of course, image registration. That is the basic thing. Okay, one more important thing, and that is related with the planning.
This is the dedicated stereotactic.
No. I have to see in closer. Okay. Okay. So. Okay. So if we. Okay. One last point. in this radio necrosis I would like to make is your max dose point. Okay. So especially if you are dealing with a serial organ like brain, you just try to keep your max dose under 125%, like we say 80% acidose line. Okay, because if we are increasing our max doses inside, like if you're going 50%, that means 200% or 200% of dose will be inside the tumor. And especially in the serial organ, we will be delivering a double dose. Not a good idea. That patient gonna develop radionecrosis. And this thing I mentioned in my last session, and why this is happening. Basically, in the brain metastatic lesions, it is an infiltrative type. So whenever it is an infiltrative type, there will always be a normal brain parenchyma within it. If you are doubling, if you are doing a 50% acidose line, that normal tissue, not just a tumor, that normal tissue will be melted down. So 50% acidose line, 60% acidose line are good with the benign diseases. Like in acoustic neuroma, there is no normal tissue inside. There is no brain parenchyma. If you are doing a pituitary adenoma radius surgery, there is no normal area there. We don't want to save there something. Okay. So we can certainly give a double dose there, 50% acidose comfortably. But in the brain metastatic settings, or especially with the serial organs, avoid your isodose line going below 80%. 75% fine. Sometimes 70% we have to go because the tumor shapes are really irregular. We have to go below 70%, 65% sometimes, but just try to avoid it. Okay. And what else left? Okay, advantages of surgery versus SRT. We discussed this thing. We discussed the surgery in detail. Okay, of course, if patient is having a mass effect, brain herniation, midline shift, surgery is always preferred. Okay, but nowadays there is a one trial going on. What they are doing, they are comparing surgery followed by radiosurgery with radiosurgery only. Although there are some retrospective data as well as a small randomized trial as well, and they mention this thing: the survival and the local control is same, especially if the size is small. So advantage is only limited to mass effect. If there is no mass effect, no need of doing surgery. Okay, and you can do SRS, you can do SRT, depending upon the facility, depending upon the size of the team. Okay, and what else? Advantages and limitations. Mostly it's equipment related. Okay, and if you don't have a dedicated system, certainly you will be limited with the sizes. You will be limited with the delivery as well. Okay, and so it's better to have a dedicated system, or at least the dedicated immobilizations. And how to draw hippocampus? I think this is a, we can skip this thing. Everybody knows how to draw hippocampus. Okay, just so just use a T1 image for the hippocampal drawing. That is the best viewed there. T2 sometimes confuses a lot, or some other image like FISTA or the BTFE, which we use for the trigeminal. So always confuse. So T1 image is the best one for the hippocampus. So draw on that. Okay. And pre-op versus post-op SRT or SRS. Okay. So last year a trial design was published, and they are recruiting the patient in those. So let's see the result. What's going to happen? So they are expecting that the pre-op radiotherapy, pre-op radiosurgery is going to give us similar local control, similar over survival. So we have to wait for that trial. But the concept is really good, because I would love to do a pre-operative radiosurgery rather than a post-op, because it's always difficult. Like in the sarcomas, we end up radiating more more difficult to draw, more time consuming. I would love to do a pre-operative. Okay, but by now we have to wait for the results of that trial, and it's still going on. We will see. Okay, but of course it's a good idea, and we can do it, but it's better to wait for the results. Okay.
What
Any-
dose do you see over hippocampus in stereotactic?
So to be honest, for the single fraction, we don't have any specific dose for the hippocampus. Okay, we don't have clear dose, but we try to keep it below 6 or 7 grade.
Unfortunately,
Max dose.
fractionated में भी pediatric में भी dose क्या है किसी को नहीं पता. सब कहते हैं कि minimize करें, control करेंगे, कोई कह रहा 30, कोई कह रहा 25.
Exactly.
Fractionated क्या dose है?
Okay, so we try to keep it at 5, 6 in single fraction, but generally if a dose is going there, we don't just push a lot, because that is not our target. Save the patient first. If it is saved, then comfortably. Well, of course, in the whole brain, we have to save it. Okay, but with the radio surgery, because if you cannot control a dose to the hippocampus with the radio surgery, you cannot control with anything else. Nothing. So if it's going there, then going. Try to keep it 5 to 6 ray. Not control, just let it be. Okay, because at least one hippocampus will be saved. Okay.
And any kind of edema which is causing midline shift.
Okay, so midline shift, don't treat. Okay, don't do radio surgery. Don't even go near to that patient. Okay, because if you are going to do radio surgery, even it's an SRT, that patient gonna have a brain herniation, he gonna die. Okay, so midline shift always first start with the supportive care, steroids, mannitol, or debulking surgery if there is a need, if there is an indication. Once the midline shift is corrected, only after that you treat with radiosurgery or the SRS or the SRT, whatever the fractionation you are going to do. Even this is true with the whole brain as well. Try to correct the midline shift as much as possible. Okay.
Makes sense, because if it is infiltrative, then that destroys the whole concept.
Exactly.
Because you wait, you midline touch you, there is something.
Hmm.
So that's pushed. जो हम अभी भी एक वो करते हैं, for margins we get into two different phenomena. One is pushing the midline and one is infiltrating the midline.
Okay. Okay. Anything else? So I think we are done with all the LOs. So any questions? So they covered the whole brain metastatic textbook in these LOs. Nothing left.
Book. And who is from outside there? Because I spoke to
Around 15 participants.
Mashallah. So उनका भी thanks करते हैं. CYPRO का certificate अलग है और एक
So just push if somebody have any question. बहुत सारे सवाल. Okay.
question, right? In the chat.
Any role of MR spectrum in follow-up in the choline peak?
So basically, choline peaks are more helpful in the glioma cases, not in the metastatic lesion. If you want to follow up, so basically it's an enhancement pattern which we have to differentiate. And if there is any doubt if whether it's a progression on the lesion or if it's a radiation necrosis, because they both look similar sometimes. So the most preferable sequence in that scenario is the perfusion study, MR perfusion study. It's really expensive. And I remember 2 years back, it was around 80,000 something here in AKU. And by now they possibly have increased to double, I think. But that is the best imaging to look into whether it's a true progression in the lesion or it's a radionecrosis. But for the follow-up scan, if you're doing a routine follow-up, just do a simple MR scan. That's it. T1 contrast, failure in the T2. That's it. Nothing else.
So how about whole brain following stereotactic for 1 or 2 or 3 minutes? So if a further lesion pops up, is that an indication to proceed with whole brain?
No.
Or because that's a very particular clinical scenario, and in fact, we often get referrals that such and such patient was treated with stereotactic for brain met, or received good indications, directly done, nice follow-up, but these patients would progress anyway since we have long-term survivors and their microscopic disease was actually the rationale of doing whole brain previously. So, one school of thought does say that proceed with whole brain when there's further progression. I believe more like that once a non-whole brain approach, it has to continue with a non-whole brain.
Exactly. So basically, it was an old concept when the people used to say, like, if patient had a radio surgery, new lesion pops out, do whole brain. Not like that. Nothing. Because if the patient is having a new lesion, just treat with the radiosurgery unless there is a contraindication or the patient is developing leptomeningeal disease. Only in that case, refer that patient to the whole brain. Otherwise, if the lesions are a limited one, like it's still 4 or 5 lesion even in the new lesion, and if you can control the doses, go ahead with the radiosurgery. No need of whole brain still.
Okay, so the rest of the questions we can send it to you, but tomorrow is your flight. I will just ask the one last question, then we'll finish, and thank you and all the participants. By the natural history of the leptomeningeal disease, it is always traditionally thought to be radioresistant, right from day 01. It is still the same phenomena or it has changed?
So no, it's not the same phenomena. So unless there is a diffuse involvement of leptomeninges, in that case, it's a radio-resistant kind of thing. Because in that cases, when we are offering whole brain radiation therapy, our doses are limited to 30 gray in 10 fractions only. That is not sufficient to produce a good local control or biological effect. So if it is a focal leptomeningeal disease like the nodular one or the cortical area, and if we can do a higher dose radiosurgery, the local control is very, very good. Higher than the one we expect in the 30 gray in 10 fraction one.
So this is another paradigm shift, because we used to do a lot of your leptomeningeal radiation, but then with a full notion to the family that it does not really, because it was thought to be radioresistant. Special history is different. And
because a 30 gray in 10 fraction previously for the leptomeningeal is not a sufficient dose. Not really, you know it, because the disease has to progress after 5, 6, or 7 months. Okay, so if it's a focal involvement, it's still radiosurgery.
mashallah, so a lot of learning points today. So
I have two questions.
दो question और तेरी पे आते हैं मैं ऐसे कौन से वाले इसके बाद में एक वो फोटो से मुझे सेशन with the group plus ये मिलते हैं because there are mehman on the other end as well, so just question from the profile up तो मैं ये दे देता हूँ और फोन आपका क्वेश्चन कितने मिनट पॉइंट
All right, so thank you so much to all our participants for joining. We are concluding the discussion, but even if you still have any question, you may just ask or drop it in the chat box. Otherwise, we are just concluding our session.
भाई 6 साल पहले हमसे कुछ चीजें नहीं पूछी अब लास्ट वीक ठीक है फिर इसको जरा
All right, thank you, everyone.
स्पेशल चीज हम दे रहे हैं आपको भी और हमारे 3 और बच्चे गेस्ट आए हैं
Thank you, everyone, for joining. The session is now concluded. Allah Hafiz.